ไหมคะ
เปิดไหมยังเปิดไหมไปเป็นยังเปิดแล้วได้ยินเหรอ
ฮัลโหลฮัลโหลฮัลโหล1 2 3 4 5
เตรียมเข้าไปเป็นสิได้ยินไหม
หนูลองก่อน
ฮัลโหลฮัลโหลฮัลโหลได้ยินไหมคะได้ยินแล้วเนาะลองดูฮัลโหลอันเมื่อกี้ดีกว่าเนาะอ๋อโอเคอันเนี้ยลองเลยโอเคฮัลโหล1 2 3 4 5
ได้ยินเหรอ
ได้ยินแล้วเนาะโอเคเดี๋ยวแชร์สไลด์เลยนะคะอ๋อส่งสไลด์โอเคตอนนี้ทุกคนเห็นจอไหมคะเห็นสไลด์ไหมเอ่ยเห็นเนาะ
ครับยังไม่เริ่มสลับกันนะ
Okay, shall we start it? Okay. Good morning, teachers and friends. Today, our group T3 would like to discuss you guys around the topic porcelain veneers, and we believe that it's not only that our team is interested in this topic, and also like many of our classmates also interested in this topic as well, as the trend of veneers has been rising throughout like the past few decades in Thailand, from what I've heard. And these are what are we going to cover, and it will also be include the case report after we discuss about all these topics. To start with the introduction about like what are dental veneers and what are the types of them. First of all, I would like to bring you guys around about the history of veneers. So it all started by the patient's demand. The patient demand to correct the unaesthetic anterior teeth, and it's the demand has been increasing like all over the world. It's not only like our country, and it has been rising like continuously, steadily, and now it's been like exponentially. And first, for many years, the like primary options for as the most durable and most predictable method to correct this problem is achieved by the full coverage crown. And however, it's undoubtedly the most invasive and it requires us to remove like large amount of tooth structures, and it can cause possible adverse effect to the pulp and periodontal tissue. And that is when the adhesive and development of like adhesive system and small particle resin hybrid small particle hybrid resin composite has come into a play. So it can lead us to more conservative way to restore, to max the tooth discoloration, to correct the form of the tooth morphology, and also can like move a little around the position of teeth. However, due to the limitation about material, it has like lower longevity and lower durability. It can have like discoloration, it has low wear resistance, and it can have the marginal fractures. So that's why in the approach for more durable correction way to the anesthetic anterior teeth, so that is when the porcelain veneers had come into play. So what are the porcelain veneers? It is the technique that includes the bonding of the thin laminate veneer to the tooth structure by using the adhesive technique and also the resin cement. and it can change the color, the form of the tooth, the shape, and the tooth morphology, and or the position of the teeth. And the success of it is greatly determined by the strength and durability between the form bond between these three components that I already mentioned. So it's the tooth surface, the resin cement, and the veneer.
And before we move on into more details about the porcelain veneers, which is our main focus for today, we would like to discuss about the types of veneers that are available in the market these days. But as CF mentioned earlier, it's still an ongoing development, so we have only chosen the ones that are conventional and are commonly used. So first, we have different types of veneers that are based on materials. So we have porcelain veneers, composite veneers, lumineers, and non-permanent veneers. Non-permanent veneers are also known as temporary veneers. It can be removed, and it is used during the procedures. So we won't go into details much about that. I'd like to discuss more about these two, which are the composite veneers and lumineers. So composite veneers, they basically use the same material as we would use in direct restorations, but it could require only one visit or maybe two visits, depending on if it's a direct or indirect technique, which I will go into details later. And the advantages for this composite veneer is that it is less expensive comparatively to the porcelain veneers. It allows for partial veneers, so if you want to correct very localized spots, you can use composite veneer as well. And the anatomy and the shape of it can be adjusted on shear side as well. But the downside for this is that it is relatively short-lasting due to the material compatibility, and it has relatively less strength than porcelain, and it could cause some discoloration. There could be marginal stain and could cause unpleasing aesthetics as well. And the next type is what we call the lumineers. It is a brand that uses the spatial patented serenade porcelain, which they claim to be very strong and very beautiful. The advantages, as they claimed, is that it is relatively stronger and thinner, and it requires less to no tooth preparation at all, and that makes this reversible. So if the patient is not satisfied with the final product, they can just remove it out. And being said that it did not remove any tooth structure, you can change it, and it has direct bonding to the tooth structure as well. But the disadvantages is that even though it is relatively stronger, but it can subject to more shipping than porcelain veneers, so that could cause lower lifespan of it. And it is not as effective in covering dark discolorations. So if the tooth is very dark or has a heavy staining, then lumineers might not be an option. So this is an example of the composite veneer, as I have mentioned earlier. This is from a case. They use the Z350 composite, and as you can see, they just build up the wall and stuff like that. They use the putty index to build up the palatal surface, and then they build up the entire tooth structure later on. And another type that you could use for composite veneer is that you could use these templates. This is from a company called U Veneer. So basically you put the composite onto the tooth structure with bonding, of course, and then you place the template over the tooth, so you know the rough structure that you can have the tooth as a final product, and then you remove it out, you cure it, and then you polish it. And next is the lumineers. They claim that while the most porcelain veneers are around like 0.5 millimeters thick, this brand claims to have it as thin as 0.2 millimeters, as thin as a contact lens. And these are the pictures from the company. Okay, and now we move on to another classification for the veneers, which is based on the extent of tooth involved. As I've mentioned a little bit earlier, we have partial veneers and full veneers. For partial veneers, it is used for when we have very localized defects, such as very local intrinsic discolorations. Or we could have a full veneer, which is a more commonly used ones, but these are also separated into different types depending on the type of preparation that is done to the tooth. So we have the common ones that we know is, first is the window preparation. So we only cover the labial surface of the anterior tooth without touching the incisal surface. And this preserves the functional surface, because when we grind our teeth or we use to bite off the food, then we use the incisal surface. So this preserves that structure. On the other hand, we have the incisal lapping preparation. So this covers the incisal surface. So the difference is just if you cover the incisal surface or not. And for the incisal lapping preparation, there are many types of preparations that could be done, but we will not be going into details about that much. So, but this is more commonly used when we want to edit the length of the tooth, or if there's the defects that are localized at the incisal surface of the tooth, we would use this type of preparation. And this is an example of the preparation that they did for the full veneer. We have the window on the right hand side, and the left hand side we have the incisal lapping. As you can see, it involves the incisal surface more. Oops. Okay, and now we move on to another type that is based on indications. This is from Magne and Belzer. Okay, so they did the classification based on the indications for the porcelain veneers. So in type 1, we would do it with teeth that are resistant to bleaching. So they did bleaching and it didn't work. We'll do that. It's classified as type 1. Type 2 is the major morphological modification. So if the tooth needs modification because of their anatomy, then it would be classified as type 2. And a type 3 is the extended restoration. So when there are loss of tooth structure, we would classify it as type 3. Okay, and now we move on to the types of veneer based on mode of fabrication. We have direct veneers, indirect veneers, and direct indirect veneers. So for the direct veneers, it is mostly used with the partial veneers, but also full veneer is possible as well. The commonly seen ones are like diastema closure, or when we want to correct the localized defects, and it usually requires 1 to 2 visits. However, the indirect veneers is mostly for full veneers and for high aesthetic work, because this is less subjected to technicians' techniques and skills. And it requires 2 visits, of course, and it is better for multiple teeth veneers, for long-lasting veneers, and less sensitive to operator technique, as I have mentioned. And the materials are in a range from the processed composite to feldspathic porcelain to pressed ceramics. We could use CAD/CAM in these, as well as our friends in the earlier groups have mentioned. And there's also a technique called direct indirect veneers. So this is commonly used with the composite material. So we did the veneer with the composite as we would do as the direct veneers, but we do not put the bonding in there. We remove it out, and then we adjust it in the lab, and then we insert it in the patient later. And that's also one of the mode of fabrications. Okay, and now we'll be moving on to our main topic for today, which is the porcelain veneers.
For the next section, it is indication and contraindication. As Samtam already mentioned that there are 2 types of indication. The first type would be the tooth that resistant to the bleaching procedure. Starting from the first group, the tetracycline discoloration. The veneer is prescribed for the case that have the heavy discoloration to the degree of 3 and 4 according to the Jordan and Bosman classification as indicated in this table. In the next group is the tooth that unresponsive to the external and internal bleaching. For the example, it is the root canal treatment tooth. As you can see in the radiographic image, this 1-1 and 2-1 receive the root canal treatment, and then no destruction on mesial and distal wall. So the veneer is being given. But in the case that have destruction of the proximal wall, like the involvement of class 3 caries, the crown would be the more suitable treatment for the case. In the next type, it is the major morphological modification. Starting with the conoid tooth, as you can see in the picture of the before treatment, the lateral incisor on both sides have the peg shape, and this can be modified by using the veneer treatment. In the next case is the closure of diastema and interdental back triangle. In the case that have multiple diastema, like this one, the direct composite does not permit the adequate and simultaneous control of form emergence profiles, cervical adaptation, and change. As you can see in the case, the next example for the morphological modification is the augmentation of the incisal and the length and prominence. In the upper lobe, it shows the before treatment, and the bottom lobe shows the after the treatment. The change in curve of the smile can change the aesthetic form and make the patient look younger, and this is due to the aesthetic consideration. And the last type will be the extensive restoration. For the example is the extensive coronal fracture, like in this case. This case cannot be simultaneously restored by the direct composite restoration. And the treatment of veneer can increase the fracture strength when comparing to the natural tooth without the veneer treatment. And another example would be the extensive loss of enamels from the case of the abrasion and erosion, like in this case. Another example for extensive restoration is the generalized congenital and acquired malformation. Like in this case, the lower anterior teeth have the generalized enamel dysplasia and can be restored by the veneer. So the contraindication for the veneer is the insufficient of tooth structure, like have insufficient posterior support or insufficient enamel to be bonded. The second one is the labioversion and the excessive interdental spacing. The poor oral hygiene and high calorie risk can also be contraindication to the veneer, and parafunctional habit like clenching or bruxism, and moderate to severe malposition or clouding.
And next, pros and cons of the porcelain veneers. And for the pros of the porcelain veneers, first, it is more conservative in preparations than crowns, since it has the enamel reductions about 0.5 millimeters or less. Next, the aesthetics. The porcelain veneers replicate the properties of the enamels as the translucency. And next, the biocompatibility to the tissues. The highly glazed porcelain surface can provide less part accumulations. Next, the porcelain veneer resists stainings since surface is smooth by glazing in the final process that can minimize the staining. And the last pros is the durability. The veneers are bonded to the underlying tooth structure with the mechanical properties of enamels and dentines, so the toughness can withstand the force from the biting. And for the cons of the porcelain veneers, first one is the technique sensitive. And another one is the susceptible to the damage. The fragile veneers can also break, chip, and crack. And the sensitivity to hot and cold food or drinks are also the complications of the porcelain veneers. And the last one is the high cost. And the possible complications after the veneer placements, the first one is the fractures. By the unfavorable occlusions, significant function habits, large dentine bonding surfaces, and bonding to existing restorations. The next one is the debonding. Debonding can occur by bonding material placement technique and bonding substrates. And post-operative sensitivity, marginal discolorations, and wears of opposing teeth can also observe as the complications. And from the meta-analysis that compared the failures and complication risk of the porcelain laminate and indirect resin veneers, it concludes that porcelain has higher fracture resistance, color stability, and mechanical strength than the resin composite. And the survival rate of the porcelain laminate veneers is much more than the indirect resin veneer, but the observation times is ranging from different time range. And the main reasons of the failures were fractures and debondings, and the secondary caries can also be reported as the complications of both veneers. And the marginal discolorations and minor defect as crack are not classified as the failure in this review. And in summary, the failure rate of the porcelain laminate veneer is lower than the indirect resin veneer, by the risk of the factors that is significantly higher in the indirect resin veneers, but there is no significant difference for the risk of debonding. And as same as the previous meta-analysis, this systemic review can also conclude that fractures and debondings are the most common complications for the porcelain laminate veneers that commonly happen within the first year after cementations. And another reason of the restoration failure is the secondary caries and the need of endodontic treatment. And the survival rate from this systemic reviews is about 95.5%.
Next, we will be discussing about the method of the veneer fabrication. It can be done in 6 methods. First, beginning with treatment planning, then we do diagnostic and tooth preparation, making an impression, and then providing a provisionalization, and then deliver the veneer. First is the treatment planning. When doing a procedure concerning an aesthetic zone, we need to plan and do the assessment of the face, looking at the patient shape of the face and the lips, the maxillary and mandibular lips line, and also the skin colors. And we also need to assess the smile by looking at the overall appearance of the mouth, looking at the incisal edge and incisal plane, and also the amount of gingiva during the speaking or smiling. And after that, we can do a diagnostic aid. One of the tools is a mock-up. Mock-up can help by, especially in the case that need crown lengthening the lengthening of the crown, and also closing a space, or in case of a mock-line teeth, mock-up is especially useful. In this case, the first mock-up that can be done is the direct placement of the composite. And this picture is the placement of the composite to close the diastema closure to let the patient see the final result and assess the aesthetic, whether it satisfies the patient or not. And another diagnostic tool is using a acrylic provisional from diagnostic wax up. We first do the wax up onto the diagnostic cast, and then make an putty index, and then make a acrylic provisional shell from the wax up, and then put directly on the unbonded tooth of the patient, and then let the patient assess the aesthetic, and then we can make the adjustment and then discuss with the patient about the outcome. And another diagnostic tool is the photograph. This is especially useful because it gives us the pre-operative data, and also we can take a picture comparing the color and also discussing with the lab technician. It's really useful for the better communication between patient and also the lab. And another tool is the computer imaging. We can do a computer Photoshop, and also planning for the patient to see if the post-operative result. And next, after planning, we can do tooth preparation. The preparation on the gingival finish line, and the key for the gingival margin is that it should be placed at the gingival place and or slightly under the gingiva. And the key is that the preparation need to be on the sound enamel, because it was proved that it will provide better stress distribution rather than on the dentin. And here the preparation at the gingival should be about 0.3 millimeter depth and 0.5 millimeter depth at the mid-facial, and 0.7 millimeter depth at the incisal. And this number comes from the average thickness of the enamel. And because we wanted to have the porcelain bonded on the sound enamel, but if the preparation on the mid facial and incisal cannot be done on the enamel, it's acceptable to be placed on the dentin, but the key is that the gingival margin should be placed on the sound enamel. And the tools that can be used to help is that we have a depth cutting burst, and this is the burst that providing a different depths, and it can help during the preparations. Sorry. And another tool is a reduction guide made from a wax up and then making a putty index. And here is the putting the press on and prepare tooth, we can see that which area of the tooth need more reduction than other areas, and it can help during the preparation to see whether we have enough preparation already. And other area of preparation is the interproximal contact area. It should not be finished at the contact area. It should be either facial to the contact area or completely through the contact area. And this is because it provides better impression details, and also it's also help the lab technician to fabricate the veneer and then porcelain veneer is more easily, and also help during the bonding process as well. And the incisal edge preparation, as we already mentioned, there are two types of preparation: the window and incisal lapping. First is the window preparation, and this preparation is done when there is no aesthetic requirement to change the incisal shape or length, and it is usually done for the maxillary canine that does not require the change of the shape configuration and also the length. And this is a preparation that provides the most protective feature during function of the teeth. And as you can see that it does not involve palatal side and incisal edge. Yeah. And another preparation is the incisal lapping. It's involved the preparation over the incisal edge about 1.5 to 2 millimeters. And this will allow the lab technician to incorporate translucency and also adjusting the length and the configuration of the crown. And here is this preparation is not protective. Is not as protective as the window preparation. And after we done the preparation, we do the impression. We use the additional silicone it can be done by either one step or two step with the double mixed impression material. Then we do after impression, then we do provisionalization. Here is a diagnostic cast, and then we do the wax up on the diagnostic cast, and then the clear metric stent is made from the diagnostic cast, and then we doing a spot etch technique on the incisal area of the prepared tooth, and then we apply a adhesive, and then we put on the composite into the clear stent, and then over the prepared tooth, and then we can see we have a gross access, and then we place the finger cover the gingival margin and leaving about 2/3 of incisal area to do the light keel, and then we remove the clear stent, doing a gauze removal of the excess composite by using hand instrument or number 12 blade, and also flossing to remove any excess composite. And we do a abrasive disc to polishing and finishing on the facial and incisal embrasures, and then we do finishing with rubber cup and applying bonding, and then light keel again, and that is a finish of the provisionalization. And the next visit we make an appointment with the patient to deliver the veneer. Firstly, we need to remove the provisionalization, and we need to clean the prepared tooth surface by using a basic paste or pumice and with a rubber cup here. And we try in the restoration individually first, and after individual tie-in, we try in the restoration in group. And if the restoration has no problem, we can put on the rubber dam and then condition the veneer surface. And also we need to condition the veneer surface and also the tooth surface. By condition veneer surface, first we need to do hydrophilic etching to provide micro-mechanical interlocking. By applying hydrophilic etching onto the veneer by about 90 seconds, and then rinse off with water, and then do ultrasonic cleaning in 95% alcohol. And the reason that we need to do hydrophilic etching is because it provides a additional retentive hole and tunnel between acid-resistant crystal. Here is a picture of a veneer surface without hydrophilic etching. And then we comparing between the first upper picture is the veneer with sandblast, and the lower picture is a veneer after hydrophilic etching. We can see that there are more holes and also more tunnels between crystal, and it provides a better mechanical retention. And the reason that we need to do ultrasonic cleaning is because after hydrophilic etching, there are residuals on the veneer, and this residue cannot be removed purely by water rinsing. It needs to be ultrasonic clean by alcohol as well. After mechanical interlocking, we need to do chemical bond as well. Chemical bond can be done by applying a silane and also iodide about 2 or 3 times, and then applying a heat treatment. And this is done because on the veneer surface there are silica on the veneer surface, and with silica content we can applying a silanization, and this process will allow the bonding between organic resin and inorganic resin, which in this case is the luting composite and the veneer. But the silane group will provide a chemical bond between the organic resin and inorganic resin, and heat treatment is necessary because it will strengthen the chemical bond by giving a condensation of the cupping reagent. And after we do a surface treatment of the veneer, we can apply an adhesive resin onto the veneer and loading a luting composite and place under the light tube. And then we treatment the tooth surface by applying phosphoric acid and rinsing and applying adhesive. And after that, we can insert the loaded veneer onto the tooth surface. But before we insert, we need to place a metric and wedge first, and then we insert. And then we remove the gross excess by using hand instrument. And then we remove the metric and wedge. And during removal, we need to ensure that the veneer is stable and remain at the same place. And then we can do the final insertion by applying finger pressure. And fine excess can be removed by brushing. And after that, we need to do curing on the palatal surface first, and then moving on to the maxillofacial surface and then distal-facial surface. And then we need to apply a glycerin gel and then a light gel, and this will prevent the inhibition of it will prevent the oxygen inhibiting layer. And then we can rinse off the glycerin gel by water. And then we need to do a hand instrument finishing by number 12 surgical blade. And after that, we do a occlusal adjustment by fine diamond burrs and also a rubber tip. And we need to check for anterior guidance, doing a protrusion, lateral excursion. If there is any interference, we need to adjust that as well. And if there is not, and if there is not, and this is about to be the last step. And here's the summary of the anatomy of the veneer. First, we have a prepared tooth surface. We etch it, and then we apply a bonding resin. And we have a etched veneer, and we apply silane, and we have applied the bonding resin, and then we meet the two together by luting composite. And here's the final result. When we do the veneer, we expect aesthetic and proper physiologic profile.
And now for the maintenance and repair. For the maintenance of the veneer, devices such as ultrasonic cleaner and air abrasive polisher must be avoided. For the surface stain on porcelain veneer can be removed with diamond polishing paste on a felt wheel or a rubber cup. And for the proximal stain can be removed with the composite proximal polishing strip. And when scaling is performed around the veneer, care must be taken not to chip off the margins. And if the topical fluoride application is required by the patient, it should have neutral pH status, stannous chloride, not the acidulated phosphate chloride. And now for the instruction to tell the patient with veneer. The patient should be advised that food and liquids with high potential for staining such as tea and coffee increase the potential for marginal staining. Patient must be aware of the potential that the porcelain can be fractured. The activity like eye chewing and fingernail biting should be avoided. And patients with parafunctional habit or in cases with porcelain veneer oppose the natural teeth, a protective appliance or occlusal guard is fabricated and worn by the patient to protect both the veneer and the opposing teeth. And lastly, the patient should be recalled after 6 months for clinical evaluation. And for the repair of the veneer, if there's ever shipping, one way to repair is to isolate the dental segment under the rubber dam to protect the patient airway from the sand inhalation. Then load the sand into intraoral sandblast blaster and then sandblast the chip surface for 15 seconds. You can also protect the other teeth with the metal matrix and then apply the silane and allow the solvent to dry with air and wait for 5 minutes. Then apply the adhesive resin, make it thin and then cure. And finally restore with the light curing composite as for the intact natural tooth. And if there is fracture of mesio-incisive portion, one way to repair is to isolate with oral retractor. Then do the initial shade selection and also a quick mock-up of the repair tool with the selected resin composites to verify the shade selection. Then 2 mm wide bevel can be placed on the porcelain surrounding the fracture to protect the adjacent soft tissue. Then edge arrest, which is sodium bicarbonate gel, is applied. Then the porcelain surface is rinsed and dry. And the silane primer is applied and allowed it to dry for 60 seconds. Then the bonding agent is applied and then cure. And finally, the resin composite is applied to the fracture site, cure, finish, and polish. And if there's large fracture, one way to treat it is by replacing the entire porcelain veneer.
Okay, now we'll be looking at some case report. This is a treatment of moderate dental fluorosis using porcelain laminated veneers. So this is the intraoral image of the patient. She is a 23-year-old female presented with permanent dentition with full mouth fluorosis, as you can see. Her chief complaint is that she has an unattractive smile due to generalized tooth discoloration. And her medical history is no known drug allergies. She's generally healthy. So the clinical findings on this patient were dental fluorosis with the TFI index of 5 to 7. And she has anterior crossbite between 2 and 3 as you can see. And there's also upper midline deviation about 2 millimeters to the right. And I mentioned some weird names about the index. So this is a Thylstrup Fischer-Scoff. Sorry if I butchered that. It's an index that classifies the fluorosis teeth. And in this case, with as we have mentioned, it is around index around 5 to 7 for fluorose teeth. And it is presented with marked opacity or chalky white appearance on the tooth surface, with pips that may occasionally be presented with diameters around less than 2 to 3 millimeters, as you can see in the image. And this is the criteria for the fluorosis. Okay, so for the treatment options for fluorosis, also it's not only just veneer is the only option. So if the patient comes with the TFI index around 1 to 4, which is mild to moderate fluorosis, then we could do some bleaching or microabrasion first because it is less invasive. as our friends have presented earlier. But if it is a TFI index more than 5, then porcelain veneers is indicated. But if there are loss of tooth structures or it is very fluorose teeth around the index around 8 to 9, then crowns may be required instead. So in this case, we recommend the porcelain veneer is indicated.
And moving on to like how the treatment plan is accepted. So we consider the age of the patient. She's still young, like 23. And if we apply the composite restoration, eventually it will have its age around like 10 years or something like that. And after like considering the severity of the fluorosis, the presence of crossbite, so the accepted treatment plan is to put the 16 porcelain laminate veneers from premolar to premolar, both upper and lower arc, and to obtain the aesthetic result and also to correct the crossbite as well. And after that, after the patient accepts the treatment plan, we do the smile analysis to evaluate the relationship between the lower lip line and the smile line. And the study model were analyzed for the occlusal relationship. After that, the wax up model we use. It is used for many purposes, like for silicone index, for provisionalization, or diagnosis, the assessment of the aesthetics, or we can also show it to the patient to assess the patient's satisfaction before we proceed to the tooth preparation. And also the final shade selection were made, and in this case they are using the ChromaSculpt shade guide. And after that, they proceed into the tooth preparation, which in detail Purinat already mentioned about it. And the significant point about this case report is that for the upper teeth, it would not be like as the same as the Purinat and Pitchmore already mentioned. Like for the incisal preparation, in this case, they say that it was a feather incisal 8. So it's similar to like their window, but like for my classification that I found is like for my window, it would not be covered. It would be like the figure A on the lower right. And however, it's a feather age, so it's a little bit about to reach the incisal edge, but not so it still remain the same incisal length. And for the lower teeth and premolar, they reduce the incisal reduction and occlusal reduction about like 1.5 millimeter. And for the premolar, it only reduced only around the buccal third of the occlusal table, like not the whole one, because it's not like the crown or partial crown. And all incisal line and groove were rounded. And after that, they do the core packing, final impression with additional silicone, double mix impression. And they do the temporary restoration. In this case, they do the spot etching and they use the composite resin, nanofill. And they did finishing and polishing. And this, in this case, the laminate veneer that they use is the IPS Impress, which is the one that is released before EMAX. And also they're using the combined press and layering technique. And after that, they do the internal surface treatment, just like Purinat already mentioned. So with the hydrofluoric acid and saline coupling agent. And the veneer fit, form, and color will assess in the master cast first, and then they will we will clean the tooth, and then we will put and evaluate in the patient's mouth. So after 1 year later, there was no tooth sensitivity, no adverse effect. It has good gingival response, no breakage, no shipping, no discoloration of the veneers. And it can be said that the satisfactory aesthetic result has been achieved in this case. And that concludes our presentation. Thank you so much for listening.
Is there any question?
I think James has a question. No, James, you don't have. Could you also check not online? Do you have any questions? No. Can I ask you from the online? No. You are here, right? Any question? Okay, maybe start by me. Oh. Okay. There is a question.
Okay, so the question is, would a patient require tooth bleaching prior to lumineers due to it being extremely thin? And what are the indications and contraindications of partial veneers? Ha. So for the lumineers, actually I haven't looked much into details about the indications and what is needed to be done. But all I know is that for the lumineers, since it is extremely thin, we do not recommend it for cases with dark discolorations. So if it's a whiter discoloration, it's fine. But if it's like a darker discoloration, then lumineer might not be indicated in the first place. But if the patient expects the final result to be like super bright, super white result teeth in the end, then tooth bleaching might be indicated in that case. And what are the indications and contraindications of partial veneers? So partial veneers one indication, of course, is that when we have a localized defect. So if it's a very small defect, like I don't think I have a picture in here, but if you have a very localized stain or like discoloration, then you could use partial veneer, of course, because it's less invasive. But for the contraindications, I think it is basically the indications for full veneer. So if you need to adjust the anatomy, the incisal length, and stuff like that, then you do not need the partial veneers. And if the tooth structure is lost a lot, even if it's a localized defect, then we would not be doing veneer. We would do say like direct restorations first. Do I cover the answer?
I don't know. You have to ask who ask you.
Did that suffice, Miss Megna?
Megna, I see. First of all, I would say the slide and the way of your present is quite good. I like it. And the time spent that you use is okay. It's fine. We still have maybe 15 minutes for the question. Maybe I will start with the question to make sure that you understand everything. When you compare between the composite veneer and the porcelain veneer, which one do you think is better?
Better in which term? Yeah, so each of them have its own advantages. So if you are very concerned about the aesthetic, if you want a very clear, very biomimetic results, then porcelain veneer is of course better than the composite veneers. But in terms of some papers say that the strength for porcelain veneer is stronger than the composite veneer, but it's depending on how much of the tooth is reduced. So if most of them said that if it is partial veneer or window preparation for full veneer, then composite might be stronger in some cases rather than the porcelain veneers.
Like for about the durability of the material, I think for after I've looked into the details, I think the success rate of veneer, like both on porcelain and composite, is quite like similar, like 90% each, and the survival rate is like 5 to 10 years, like almost the same. So I think it depends on the patient's expectation about the aesthetics. I think because the final look of it, like if it's porcelain and it's composite, they look different. And also,
okay.
yeah.
Okay. Good. Not too long. It's okay. No, I asked a short question on purpose because when you present, it seems like for the audience, maybe they might think the porcelain is better. But actually, it depends, as you said, it really depends on the case, it depends on the severity, or depends on how much the tooth you have to keep or to preparation. That's quite important because nowadays outside in the clinic, a lot of people or dentists try to over treatment. Sometimes it's just small correction, but they decide to do porcelain veneer. Actually, the composite veneer still have a lot of advantages. For example, as you said about the preparation for the tooth preservation, Also, the year, as you said, the survival rate is around 10 years, okay. But after that, what happened? People tooth color change all the time, but the porcelain doesn't change, right? Then you have to replace it. It depends on how much the tooth preservation that you keep. Okay, so it depends on the case and benefit of each one have different. That's fine. Okay. But I just comment because when you present analysis, you present everything is really good, everything is perfect for person video, but the audience, if they don't understand well, that might be a problem. Second thing, you present, this year is 2022, but the paper that you present is from 2002, actually 20 years ago. No, I really not complain about it because the detail from magnet and browser, the detail or indication and so on, many things is still updated. But the other side, something is not updated anymore. The problem is, if you don't have experience, you could not really see what the problem, which point is not really updated, which point is really already updated. Okay, so for indication and so on, for the technical advantages and everything is still updated, in my opinion. But the thing is, the material is not updated anymore. The material, the way that you treat the material, I think the material that you use. Firstly, I think mostly pool, right? You present the case from that paper, I think. And firstly, the temporary, they use a composite, and I think they spend a lot of time and quite long for the temporary, and we can really see that the gingiva is really not so good, bleeding a lot and so on, right? Before you put the temporary, it's not like that, but after temporary, you have to remove a lot of excess of the composite. And nowadays we have different. We have protein, I think it's a temporary resin, but also kill, and it's easier. It's not difficult like that, and we also have the different metric. We don't use we have different techniques, and actually that technique is not wrong, it's correct, but different technique or better technique or easier technique that you also can use. There is not only one way to do. Second thing about the material is, I think in 2002 they used just feldspathic, right? And you said for the feldspathic, and you really mentioned for pool, you mentioned that they use hydrophilic for 90 seconds, right? But then I think, you present the case or see, I can see, right? You use 3 minutes. 4 minutes, right? HF, right? Yeah, that's different. And sometimes at the moment it's maybe not correct anymore because it depends on the material you use. You should really point this out to the audience. It depends on really on the material for etching. Etching concept is correct, but the minute or the way to treat is different. Okay, it depends on the material. Who also mentioned about the etching, and they remove the residue something with the ultrasonic, right? That is a good way to do, but actually it's not only one way to do. The other way also can possible. Rinsing is okay, but you have to rinse longer enough until you remove everything. Okay, you see the paper from 2002, they use the polishing. Do you know what kind of the polishing they use? I mean, you can see that like look like the frame shape rubber something, right? Do you know what is that? It's a silicone or it's a rubber?
I think it's silicone.
It's silicone. They mentioned it's silicone.
Yes.
Really? Okay.
And
It's,
during the polishing of the final veneer.
yeah.
textbook mention silicone.
Mention silicone. If it's silicone, it's okay because as I said, it since 2002, right? It look like the brownie and greenie. You know brownie and greenie for mocha, but actually, you also I would say in 2002, I graduated in 2002 actually, and then on that day we don't have the silicone yet. We have just the rubber. Okay. We used to use the greenie and brownie for composite polishing. Yeah, and you have to, and you see, many things have changed, right? That apply that I just comment because you took it from the book or the paper?
This one is from the textbook.
From the textbook, yeah, yeah. But as I said, you need to update many things. Okay. Johnson, do you have any comment? No? You have? I would like to introduce this is our new staff อาจารย์ไกรสอน
I think Tom already asked almost everything, but I have something to mention about the preparation. Sometimes when you change the shade to brighter, it's easy to see the difference shade between the porcelain veneer and the structure at the proximal side, especially at the mesial of the lateral or canine. So you need to focus on preparation at the proximal, especially at the cervical part. You need to breathe more purgatory. We say is the elbow breath. You can listen more about this. Okay.
That's a question or a comment? Just comment, right? Okay. Anything else, James? No? Why? Normally you have a lot of questions. Huh? You have questions?
We have a follow-up question from
Okay.
Rebex. So
Yeah.
Meghna also asked, then would it be easier to repair porcelain veneers when compared to composite veneers?
I think if my understanding is correct, we both repair them with the composite, right? So if we're going to repair the porcelain veneer, we just add one more method to the porcelain. So we just add the silane part, and other than that, it's the same. It's like adhesive, bonding, and then just
No.
put a composite, right?
No.
No.
You have to go back to who told you about how to fix the veneer. The process of the fixing the veneer who mentioned about the 6 layer or something, right? It's like when you treat dentine or enamel, you treat with something, but if you treat the porcelain side, you need different way to do, right? It's not just the silane, but the porcelain side, what you treat, you etch, right? For sandblasting, we are not recommended because sandblast could crack the veneer as well. So you need to separate well, and especially separate dentine, and you use the HF on the ceramic. Okay, that's why you really need to know how to bond with several substrate before you repair. The question from Meghna, I think is not different. You use the same way to do, but you really need to know how to treat the material. Other things. Another question? No? Okay, if it's not 1 minute to 9, thank you for your presentation today.
ขอบคุณค่ะขอบคุณค่ะ
James, don't forget to send me it. And you also you will have to present. You send me the quick presentation that you present. Okay.